Welcome to Eye Contact, a video news program on issues and controversies in ophthalmology sponsored by EUROTIMES. I'm Sean Henehan. We're here at the 33rd Congress of the ESCRS in Barcelona. This year, Richard Packard will be delivering the Binkhorst Medal Lecture titled The Evolution of Capsulotomy. Today, we're speaking with Dr. Packard, who is a consultant surgeon, Prince Charles Eye Unit, Windsor, UK, who will take us from the early days of using crude forceps to the present and future of precision lasers. Welcome, Dr. Packard.
Thank you, Sean. Good to be here.
Perhaps you could start with a personal perspective. How did you learn cataract surgery? What was the starting point, and how did that get us to where we are now?
When I qualified as a doctor in 1970, I know it seems a long time ago now, we were asked to apply for a whole series of first appointments at our teaching hospital. My hospital was the Middlesex Hospital in London. And it just so happened, by chance, serendipity, that I ended up with a job that consisted of ophthalmology and dermatology. I didn't really like the dermatology. I quite fancied the ophthalmology. And the first group of consultants that I worked with, one was at the time the Queen's ophthalmologist. He was a very, very fine cataract surgeon. He used a Gracie knife, and he used his left hand for left eyes and his right hand for right eyes. And I never saw any complications from his surgery in the 6 months that I worked for him. One of the other guys was Derek Ainsley, who was one of the pioneers of keratomileusis in the UK and a very fine corneal surgeon. And finally, there was Peter McFall, who worked with Sir Stuart Elder to write the book on tumours for the system of ophthalmology. And it was a pretty good start. I then went off and did a whole load of other things: general surgery, general medicine, bit of neurosurgery, bit of plastics, and finally came back to ophthalmology in 1975 and was lucky enough to get onto the house at Moorfields Eye Hospital at High Holborn. The branch no longer exists, had been amalgamated with the main hospital, and came under the influence there of some remarkable men who really taught me my first skills. I really started doing big numbers of cataract surgery there, all intracaps at that stage, never seen a lens implant. And in fact, the first lens implant I saw was in Santa Monica. And I went over there for a course in, I think it was about 77, and that was with intracaps as well. I saw one in extra caps whilst I was at Moorfields, and that was by chance because the capsule broke when the surgeon involved, it was an intumescent cataract, was trying to pull it out with a cryoprobe, and he had to convert to an extra cap. Then when I finished there, I got the senior registrar job at Charing Cross Hospital in London with a remarkable man called Eric Arnott. And I had sort of been dimly aware of what Eric was up to in terms of phacoemulsification, but the day that I arrived at Charing Cross, they were doing a phaco course and putting lens implants in. This was like St. Paul's conversion on the road to Damascus. Suddenly, my whole world changed in the most extraordinary way. And I learned phaco. I started doing phaco in 1979, which is way before most people in the UK. I started teaching phaco very shortly after that. And really things started to get going from the UK point of view in phaco, really not until the end of the 1980s, early 90s. We were very slow compared with many countries. But along the way, I was quite fortunate to have Eric's involvement. Because of him, I met, in the course of the time I was senior registrar there, Charlie Cullman, Bob Sinski, Henry Clayman, Jim Little, Jan Wurst, Cornelius Binkhorst, to name but a few. So I had a very, very extraordinary start in my career. Then we move on, and I'm teaching phaco all over the world. I'm involved with new implants. I was the first person to put a hydrophobic lens into a human eye in 1990. I introduced new machines all over the place. And ultimately, with all the teaching and everything else, I got asked this year to do the Binkhorst.
Well, now you've seen it, phaco go from the resistance to acceptance to almost just a standard practice. Now we have the femtosecond laser. There's still a lack of consensus on the value of femtosecond laser-assisted cataract surgery. What is your view on femtosecond laser?
I think it's a quite remarkable piece of technology. There's no question about that. It does things that we're quite good at doing as well. Capsulorhexis, breaking up the nucleus, making incisions, but it does it in a more precise and consistent manner. However, there are issues in this regard, not the least being the huge cost of investment in the technology, the ongoing costs of servicing, the costs to the patient of providing the patient interface, and as yet, the published results, and it may well be because the published results have been from very fine surgeons who would get good results anyway, there really is almost no difference that you can discern from the patient's point of view in terms of outcome. And I think that's a big issue. Many surgeons who do have femtosecond lasers don't actually use them to make incisions because they believe that the incisions that they can make with a good knife is actually better. The most important thing that people really find they like about the femtosecond laser is actually the making of the capsular opening.
Mm-hmm. Mm-hmm. Now, are you concerned that trainees, who are always going to be most excited about the latest technologies, will be losing some of the classic skills that were required before femtosecond options came along?
I think in the early days I would have said that more than in a way now. Certainly when femtosecond lasers first came along and the rate of getting a free cap with the laser was relatively low, and quite often the capsule had to be teased out and with a pair of forceps and it might have not been complete, then yes, not being able to do a capsulorhexis with a pair of forceps could be an issue. I think now things have moved on in that regard, and that where you've got more or less 100% free caps with virtually every system, that particular skill is not so important. And certainly it would be quite nice not to have to do a capsulorhexis, but to do the capsulotomy some other way and know that it was always going to be right. As we've discussed incisions already, I think that yes, people do need to know how to make incisions. Phaco-chop, yes, I think everybody should know how to do that. And even if you look at the cataract surgery that's being done with the femto, a lot of these skills are still needed. They're not going to be lost completely.
Well, let's look down the road a piece. You're involved with something called Capsule Laser.
Mm-hmm.
Tell us about that.
The laser that, the femto laser is a pulsed laser, and it causes optical breakdown and plasma formation at the point of lasing in the capsule. And multiple shots are required to enable you to open the capsule or to do anything else with the laser. What the capsule laser does is something wholly different. It's actually a thermal laser, and the way it works is to create a target within the capsule. And you create the target in the capsule by staining the capsule with a vital dye. We use trypan blue, and because of that, the laser has a particular wavelength which is picked up, and what it does is to turn the collagen, type 4 collagen in the capsule into amorphous collagen as it makes its circular excursion. Now, amorphous collagen is interesting because it has different properties from type 4 collagen. It's much more elastic and tougher, and certainly some of the tests that we've done in this regard show that you can stretch it more than you can with certainly a manual capsulorhexis and probably a femto capsulotomy as well. So this is a useful thing. It's a very small device. It bolts on the underneath of any microscope. It has a small console that comes with it. And what that means is that unlike most lasers, at the moment femto lasers, which are very large and may require a break in the normal pattern of flow of your surgery, whereby the patient first of all has to go to a laser room, have the laser work done, and then come to the operating theatre, this just fits into your normal pattern, because it takes up no room in the theatre. And we believe that this will be very attractive to a lot of surgeons who would like to do precise laser surgery of this type and who are attracted by the idea of having a laser that does at least the capsulotomy, because they may have other lesser concerns about the other parts of the procedure.
Well, we'll look forward to hearing more about that in the future. Thank you so much for joining us.
Pleasure. Thank you very much, Sean.
Thank you for joining us. For more information on this and related topics, please visit us at eurotimes.org.